Today I'm going to speak to you about our experience of ECMO in respiratory failure in Korea. So as you know, the number of ECMO runs are increasing globally, especially after the 2009 H1N1 influenza. And Korea is here. Here is Singapore, so it's around 6 hours flight from Korea to get here. Korea is known for its electronics, maybe Hyundai cars, and this is K-pop, BTS, and K-drama. But what about ECMO? How are we good at ECMO? What do you think? I will show you the data. So I show you three kind of data, two database, and one. At the end of my talk, I will share with you our experience at my center, Samsung Medical Center. So this is the paper. Is written by your chairman here. Is about our analysis of national insurance data. And Korea has a very peculiar system that most of the hospitals are privately funded and owned, but there's only one insurance company, which is the government, and everyone has to be in the system. So if we analyze the insurance data, we can get the whole country's overview of the whole country, how are we doing on special things like ECMO. So we analyzed the Korean insurance data from August 2009 to July 2014, which is a 5-year period. But there was a major limitation in analyzing in this data because in the insurance data, it did not have a different code for VA and VV. So the number of patients who were receiving it, we could not differentiate from VA and VV. That's the major limitation of our data. And because it's insurance claim data, there's less clinical prognostic factors that we can adjust for. So those are the two major limitations. So this is a kind of busy slide, but compared to the general ICU patients, ECMO patient, there was 6,078 ECMO patients who received ECMO during the 5-year period, which is about 0.48% of all ICU patients. The patients who received ECMO were younger. They had more comorbidities, and they were done in the tertiary referral centers, and they were more sick. And in-hospital mortality was 63.4%, so quite lower than the ELSO data, which is the survival is around 60%. This is the longitudinal graph showing the number of runs for each 1-year period. In the first year, there was around 750 patients receiving ECMO, but when you go by the 5th year, the number of ECMO runs really increased very much, and about 2.5 times. So it was more than 700 runs of patients who received ECMO. So the number of ECMOs is increasing, just like the other countries. And the number of centers that were doing ECMOs was also increasing. As you can see, in the first year, there was around 54 centers doing ECMO. But by the last year, the 5th year, there were 85 centers doing ECMO. So during this short period of 5 years, around 30 centers, new centers, took up ECMO. And as data Professor Fan showed, the number of ECMO volume was related to mortality, as centers that had less than 20 per year had a higher mortality than centers that had more than 20 patients per year. And these are the factors that associated with mortality: age, comorbidity, ECMO volume, and need for CRRT. So just like the rest of the world, the number of ECMO runs are increasing very rapidly in Korea, and this hospital ECMO volume is associated with survival. The second data I'm going to show you is the Korean ECMO Registry for respiratory failure. It's a retrospective database of 16 university-affiliated hospitals in South Korea. And the study period was from January of 2012 to December of 2015. And during this period, 5,552 patients received ECMO support in Korea, and these 16 centers had 2,472 patients. So I guess this registry takes up around 40% of the whole ECMO. And in all, we had 487 patients who received VV ECMO compared to 487 patients in this cohort. So we in Korea, a lot more VA ECMO is done compared to VV. So these are the 16 participating centers. Like everything else, many of the centers are concentrated around Seoul. So in Korea, everything is concentrated around Seoul. But we had good representation from other parts of the country as well. And we've set up a web database where each center could log in their data. And we published the result of this cohort in critical care this year. So the baseline characteristics is the age of 58, and 2/3 were male, and they had an Apache score of median 21, and preserved score of 5, and RESPI score of 0. And many of them were on vasopressors, and most of them were on mechanical ventilation. Around 30% had been on prone positioning before doing ECMO, and 45% of the patients were on neuromuscular blocker. And we divided the patient into 4 periods. As you can see, the number of patients is increasing. So as the year go by, the number of ECMO runs are increasing. The age stays the same, when these severity scores also did not differ between periods. But there was an interesting increase in adjunctive treatment. And as you can see, especially in prone positioning, after the PROSERVA study was released, there was a huge increase in percentage of patients that were on prone positioning, and also number of patients with on neuromuscular blocker or increased as the time went by. And this is the ventilator parameters that the patient received. And as you can see that the driving pressure, although it's the median seems to be similar, but there were decrease in there was trend for decreasing in driving pressure, and also the minute ventilation there was a trend for decreased minute ventilation as the time went by. And this is the most of the patients. These were respiratory failure, so they were mostly in VV ECMO. But there were huge differences in number of patients that were on ECMO among centers. And we are number one. Samsung Medical Center was number one. And 7 is Asan. But there were many centers that had very low ECMO volumes in our cohort. This is the survival. This is the number of ECMO patients, and this is the weaning rate, and this is survival rate. In 2012, the survival was 30.8%, but it showed a slow increase in survival as the time went by, and there was a similar trend for weaning also. The causes of death were sepsis or multi-organ failure in most of the patients that could be verified. And this is the weaning and survival of ECMO by age. As you can see, the weaning and especially survival, there was an age-dependent decrease in survival in our cohort. This table shows the multivariate analysis for mortality. So age and patient who received corticosteroid, CRRT, and driving pressure and ECMO duration were all independently related to mortality. But this is a table showing the performance of prediction models, and in our patients, the models did not do that well. This is the original AUC, but in our patients, the AUC was much lower than the original publication. And we have another paper coming up that will make a prediction model with our data. This is the weaning and survival rate by ECMO center. Just as previous speakers showed, that low volume centers did much worse than high volume centers. So in the ECMO situation in Korea, there's a very varied. It's a very varied situation. So a lot of big centers have a lot of volume, but there are a lot of centers that are doing a few runs, and maybe that is the reason why our survival rate is not as high as the international rate is. And this is the hospital that I work in, Samsung Medical Center. It's in the heart of Gangnam area of Gangnam Style. So, it's a 2,000 bed, very tertiary complex, and we see a lot of patients, around 2 million outpatient per year, with about 45,000 surgeries per year. And in 2012, our president at that time tried to restructure critical care, and in 2013, we established the first department of critical care medicine in Korea, and this is a ceremony to commemorate that occasion. And in our department and center, we try to have a system that can benefit the patient, with the evidence that we thought that would be the best best treatment modality for the patients. So so we had our ECMO team and early mobilization team as the two primary things that we would focus on to help the patients that were in the ICU. So our ECMO team is one roof, one system. And we consider it as a core function of our center. And it was a collaborative effort between Department of Thoracic Surgery and our department and center. And we established the first mobile ECMO service in Korea, and the only air mobile. We had a helicopter. We used a helicopter for that. And we established the CPR service and ECMO training program. Also, we established the ECMO Registry. And we have a yearly report, and this is me. And there's a lot of people that were very essential in this endeavor. He is a cardiologist, and he's a pulmonologist, cardiologist, and thoracic surgeons. We all have contributed with our devotion. We devoted a lot of our time to make this work. And we have the ECMO team rounds daily and discusses features with the bedside, at the bedside with the team that's taking care of the patients. We have an ECMO conference. Also, we set up a formal ECMO training course, and many of the doctors and nurses from the Southeast Asia came to our center to learn about ECMO. And this is an occasion to celebrate our 1,000th case of ECMO. And this is our result. As you can see, we started from doing ECMO in 2004. As you can see, until 2012, it increases, but it does not increase as much. But after we established our center and an ECMO team, you can see a big increase in the number of ECMO runs. In 2015, we had a MERS at our hospital, so we had to shut down the hospital for 2 months. So that's why the number is decreased. But currently, we are doing about 150 ECMO runs per year. This is the mode of ECMO, and this is VA, and this is VV. As you can, similar to the national data, you can see that more VA is being done in our centers. But after our center was established, the proportion of VV has been ever slightly increasing. So we are doing around 35 cases of VV ECMO per year. And this is the outcome, and this is the weaning, and this is survival discharge. As you can see, after we established our program, both weaning and survival percentage increases rapidly. And now we are about 70 to 75% weaning and around 60% survival. Our VV ECMO outcome is slightly lower than our overall survival, as the weaning success is around 60 to 65%, and our survival discharge is around 50% currently. And we analyzed the effect of multidisciplinary ECMO team on clinical outcomes in severe acute respiratory failure. We try to analyze the pre-ECMO period, which is from 2012 to 2013, and post-ECMO team period, 2014 to 2016. And this is the baseline characteristics. The patients were similar, But as you can see here, the post-ECMO period patients seem to be sicker with a significantly higher Apache score and higher SOFA score. But the successful weaning period, even though they were sicker, they were more successfully weaned off the cannula, and there were less complications associated with ECMO. So I think this multidisciplinary team approach to ECMO really helps the patients that we see. And there were significantly higher overall survival, 1 year survival in patients who were treated after we established our ECMO team. And this is the summary. The use of ECMO is increasing in Korea. ECMO outcome for respiratory failure in Korea is improving, but there is still room for improvement. And at our center, organized approach has led to improved ECMO outcomes. Thank you for your attention.
Thank you, Professor.